Hello, my name is Mark Munger. I am based in New York City and I'm associated with the Plexus Institute, which is a complexity science think tank based in healthcare trying to apply complexity science problems to seemingly intractable problems. You must know that many people believe the U.S. healthcare system is radically broken. 1% of our patients account for 30% of our costs, according to some economists. These so-called super users make many, many hospital visits, and there are a number of errors that result in their treatment, duplication of effort. It's also widely thought that 50% of healthcare expenses occur in the last 2 years of life. So a person's life budget, if you will, of healthcare accounts in the 2 years just before leaving life. One of the problems of reform in this system is political. A second problem is organizational, institutional, and cultural, in which many healthcare organizations don't realize either the severity of their problems or see them as economic problems. So with the assumption that the healthcare system is terribly broken, part of the question is how one measures the brokenness. It can be measured in economic terms, in terms of the percentage of our GDP, but also needs to be measured in human terms. Roughly 100,000 people a year die of hospital error. Of that 100,000, 20,000 deaths can be attributed to MRSA infection and other hospital-acquired infections. If there were a 747 crashing every day, we would begin to accumulate wreckage and be more curious about this disaster than we currently are. So the question is, are there any ways to think of hope, to look at what's working in the healthcare system that's happening below people's consciousness or imagination, and why change in healthcare is so slow, what the resistance is? For example, we've known regarding hospital-acquired infections for 100 years that to wash hands and to practice good hand hygiene reduces infection, but it's very difficult in many hospitals to practice that. Some studies suggest that as many as 300 hospital personnel will touch directly or indirectly a patient in the course of a hospitalization, and it requires that each member of that chain of care, chain of continuity, be quite alert and quite disciplined in washing his or her hands and taking other appropriate hygienic measures before going into a patient's room or actually coming into contact with the patient. But over the past 7 years, 8 years, under funding from the Robert Wood Johnson Foundation, 6 beta site hospitals began to initiate their own performance management improvement efforts using an approach that's asset-based. And instead of looking at why people don't wash their hands, they began to look at why people followed good practices. In effect, why do people do what they know they should do, whereas some of their peers do not do what they should do? So a group of people came in and investigated and began to inquire using a technique called a discovery and action dialogue. What's the state of your awareness about hospital-acquired infection and how is it practiced on this unit? And to their surprise, and their happy surprise, they learned that some people were able to wash their hands 100% of the time. The inevitable question then was, what do they do? How do they do that? And the inevitable answer was, let's go and find out. So this began a process of inquiry that generated very illuminating data, why some people with the same constraints and same resources could have much better outcomes than people just like themselves. Once this social proof emerged that someone just like me could do better than I'm doing, I was then inspired to learn what that person might do, and I would follow him or her and try to learn their practice, and I would practice it until I was better with it. And guess what? The outcomes got much, much better. And people who began to create scorecards of infection reduction, the normal metrics, but also days passed on a unit without infection, began to be very motivated that they were making progress. And in fact, after a 2-year period, sophisticated research indicated that infection in these hospitals have been reduced by 73%. And further research indicates that that outcome has been sustained. So the question is, what made it sustainable? First of all, the community recognized that it had a problem. Secondly, that community discovered that there were people who had better outcomes than others. Third, they tried to find out what those people did. Once those discoveries had been made, then there was an effort to practice and disseminate those strategies, and that worked. 73% reduction, and nurses who have a concern for budget but also a concern for other things were able to reflect. One nurse in particular said, I came into medical situations and healthcare as a calling. I believed it was noble. Based on the data that we had that would have projected harm of infection, 19 fewer people did not leave our unit this year in body bags, and that's what my life is about. There are two other examples in which you might be interested. One is a man who unfortunately is no longer with us, who died last year, a transportation orderly at Albert Einstein Hospital in Philadelphia, Pennsylvania. Jasper was a transportation orderly, and his job was to move people around the hospital in wheelchairs and on gurneys. Jasper was a sophisticated, conscientious man who believed it was his duty and his responsibility to protect people from infection. Not just protecting patients, but protecting his peers and colleagues, other doctors and nurses. So Jasper, on his own, but with some support, developed a way to disentangle himself from his protective clothing and found a way to extricate clothing and gear that might be quite contaminated with microbes, which could pass on and cross-contaminate other surfaces or other people. He found a brilliant way to dispose of his contaminated outer garments, his gear. And he took great pride in making a short video which showed him doing this. And he became celebrated and became a local hero in his hospital. And it became known as the Jasper Palmer Method. And before his retirement and then his unfortunate early death, Jasper thought of his legacy as having saved infection from people who would not volunteer for it and helping promote healthy lives.
Hello, I'm Jasper Palmer from the Albert Einstein Medical Center Escort Department. I'm here to show you a simple technique of disposing of isolation gowns after contact in an isolated room. It's a method that's very simple. Notice the gown has been inverted. Now I start to make a nice little ball. This prevents from air from getting in and making it too hard to handle. Nice slow roll over and over. And observe the glove. Grasp in the middle. First one goes over the top, and the second one goes over that, creating a nice little ball that you can now dispose of in a trash can, anywhere from 50 to 150 with no spillage. Thank you.
So part of the task of innovation in any large complex institution is how to innovation move from one unit to another. Particularly people are apprehensive about best practices, and although evidence-based medicine is our standard of care, often evidence-based is variable in its application. So people within the hospital began to think about how to take an innovation like Jasper Palmer's and diffuse it or spread it. And one of the things they did is that who'd be interested in this? Well, there's some obvious targets. The environmental services group doesn't want to handle toxic Superfund materials. So they became a very quick audience because Jasper was able to show them how to protect themselves from a possible cross-contamination. But more important, nurses and doctors who put on and take off protective clothing and protective equipment, personal protective gear all the time, they needed to know how to do this. So this dissemination began in many ways. People began a whisper campaign. Have you seen what Jasper Palmer produced? People invited Jasper to come to their units. People had coffees where Jasper was the celebrity interview. And people began not an urban myth or legend about Jasper, but it occurred to people that there are many people with great skills and great competence who have hidden solutions in our hospital. How do we uncover them, and how do we start acting in ways that promote the building of social networks, so we get out of our silos, we get out of the usual ways of doing things, and we start to learn from people like Jasper. And the last piece of it was Sometimes people are reluctant to leave their duty stations and go someplace else. There develops some informal, self-organized training about asking people to come to a meeting and saying, what would it take to get you there? We've got something pretty interesting, which is Jasper Palmer's innovation. Have you heard of that? Oh yeah, I have heard of that. Why don't you come? There'll be coffee. What would be a good time for you to come? So they try to make it as convenient and easy and culturally consistent as possible. And actually Jasper had an interview with the chief executive of the hospital and showed him how to do it, and that became kind of a joke that the chief executive practiced taking off the personal protective equipment.